Hello, my name is Leon Menezes. I'm a consultant radiologist and a nuclear medicine physician at the Institute of Nuclear Medicine at UCL and here in the Barts Heart Centre. This series of talks from the British Nuclear Cardiology Society we've recorded is to give you the basic grounding in nuclear cardiology, the applications, the technology and the evidence. We hope you find them interesting and useful. In this talk, I'm going to discuss stress testing and imaging protocols in nuclear cardiology, how the patient is prepared and undergoes a stress test, and then how the images of the patient are acquired. The principles of any perfusion imaging is that the tracer that you're going to use, the agent that is going to make the pictures, is going to be distributed in proportion to coronary blood flow. And that's stress conditions create a flow disparity between those regions which are supplied by normal arteries and those regions which are supplied by stenosed arteries. The perfect perfusion imaging agent would have a one-to-one relationship, therefore, with myocardial blood flow and its extraction into that tissue, the heart. However, at high flow rates, many perfusion agents actually tail off in their extraction. So this means that there's relatively less signal to be imaged at those higher flow rates, which means that any discrepancies between normal and abnormal might be harder to see. So the perfect perfusion imaging agent in this respect is oxygen-labeled water. The other PET tracers, fluoropyridaz and ammonia, only tail off to a lesser extent at high flow rates. Thallium, rubidium and MIBI tracers tail off to a greater extent. What we're trying to exploit is essentially this same dog experiment performed by Lance Gould, where he demonstrated that resting flow is maintained across stenoses until they reach around the level of 80 to 90%. However, if you were to cause hyperemia and increase that maximal flow across the stenosis, the flow comes down, is decreased at around the level of 50%, and therefore we need to recreate that hyperemia. So this is a common concept, that of the ischemic cascade, saying that the clinical scenario, the one of angina, is actually rather late in the sequence of events, and that perfusion abnormalities happen beforehand, such that you can get ischemic ECG changes, you can get regional systolic dysfunction, what we're exploiting in stress echo, regional diastolic dysfunction, but earliest perfusion abnormalities when there's a decrease in coronary blood flow. So this implies that perfusion techniques will have a greater sensitivity, at least for disease, because they're the first thing to fall in the ischemic cascade. How do we do that in the clinic? The first way is the most natural way, I suppose, and that's exercise stress testing. Putting a patient on a treadmill or on a bicycle ergometer and seeing how far they can go. There are contraindications to exercise, the absolute ones, if the patient is suffering from unstable angina, if they have decompensated heart failure, uncontrolled arrhythmia, uncontrolled hypertension, if they've recently suffered a myocardial infarction, if they have severe pulmonary hypertension, or if they have severe aortic stenosis. Endocarditis, myopericarditis are also contraindications, as is acute aortic dissection and pulmonary embolism. Relative contraindications are LV outflow tract obstruction and significant left main stenosis. The patient would perform the modified Bruce protocol, and if there's ST elevation, progressive QRS broadening, dysrhythmia or ectomy, then you would stop the exercise test. Similarly, a fall in systolic blood pressure, 20 milligrams, or an excessive rise in that blood pressure, stop the exercise test. However, many patients can't exercise. They're unable to reach that target heart rate. They have other comorbidities, which means they simply can't cycle or run, and therefore, for the reasons of practicality and throughput within a nuclear cardiology lab, pharmacological stress is very well favoured, despite all the additional prognostic and physiological data that you do get from a treadmill test. There's a range of agents we can use to cause pharmacological stressing. They range from the vasodilators, dipridamole, adenosine and Regadenoson, and then the chronotropic and inotropic agent, Dobutamine. I'm going to concentrate on adenosine and Dobutamine mainly, simply as those are the ones which are used most regularly. So So as I say, why do a pharmacological stress test? Well, is your patient unable to exercise, or do they have one of those aforementioned contraindications to exercise? Do they have an uninterpretable ECG because they're paced, or they have left bundle branch block? Are they on certain medications, which means they can't exercise? And again, are they actually more acute patients recently within myocardial infarction? Period. There are contraindications to adenosine. Severe asthma, COPD, really active wheezing is one of those. If the patient is hypertensive or has got severe bradycardia, they must be decaffeinated for at least 12 hours without tea or coffee or chocolate. If they're on dipyridamole, you have to stop that beforehand. Similarly, aminophylline, stop that for a day beforehand. And if they have a high degree of AV block or sick sinus syndrome, the adenosine might potentiate that. But this is the principle that we're trying to dysregulate, I suppose. We have a stenosis here in one limb of this coronary, but because of coronary autoregulation of flow, blood flow is maintained across that stenosis, and perfusion is symmetrical. If we cause hyperemia, blood flow across that stenosis is no longer maintained. There's a reduction in blood flow, and therefore the image that we would get, because perfusion is reduced, is a heterogeneous image, and that's what we're trying to recreate. Now, it's true that with adenosine and dipyridamole, we can augment coronary blood flow up to about 4 times, dobutamine up to about 2.5, and exercise gives us over a doubling of baseline coronary blood flow. So we can actually provoke greater discrepancies between rest and stress with the vasodilatory agents. Just to remind you of the cardiovascular effects of adenosine, the ones that we're interested in here are the ones on the smooth muscle in the arteriole, such that there's a vasodilatation because they relax. However, there are effects, chronotropic effects on the sinoatrial and AV node, such that you might exacerbate sick sinus syndrome or pauses, and there are obviously effects on platelets and thrombus and platelet aggregation. When we give adenosine, and the usual regime is 140 micrograms per kilogram per minute for 6 minutes, the changes in heart rate and systolic and diastolic blood pressure are modest, such that it can be hard to tell if the patient has been adequately stressed. If there are symptoms, then you might also assume that they've been stressed. Adenosine is tolerated very well on the whole, but you might want to stop if the patient suffers from bronchospasm, severe hypertension, as I say, symptomatic heart block, or again, if they do develop severe chest pain with ST depression. The side effects that the patient might experience, most commonly flushing, chest pain, which is not related to ischemia, shortness of breath, headache, nausea, dizziness, unusually hypertension from which they feel symptomatic, only in 5% of cases. These side effects can be attenuated if you combine the pharmacological stress with low-level exercise, and that simply means hand grip, isometric exercise, or a gentle pedal on a bicycle or ergometer, and that reduces the intensity and duration of the side effects, and actually helps the images because it reduces splanchnic circulation, and therefore you get better pictures. If a patient can't receive adenosine, then dobutamine is your next alternative. Again, patients unable to exercise, and if they have a contraindication to vasodilator stress, consider using dobutamine. Again, the contraindications to this is the patient within 1 week of a myocardial infarction. Do they have uncontrolled unstable angina, uncontrolled hypertension? Do they have aortic dissection or a dysrhythmia, which will cause them some sort of hemodynamic or symptomatic compromise? Again, left ventricular outflow tract obstruction related to hypertrophic cardiomyopathy or severe aortic stenosis is a relative contraindication, and the patient should be off their beta blockers for 2 days beforehand for the test. Otherwise, that will blunt their tachycardic response that we're trying to achieve. The side effects of dobutamine: chest pain, palpitations, dizziness and flooding, flushing, dyspnea, headache, dysrhythmia. And again, dobutamine is given in a standard regime of incremental increase of 10, 20, 30, 40 micrograms per minute per kilogram until you reach the 85% of the age-predicted maximum heart rate. Much more simpler to administer is Regadenoson. This is a more selective adenosine AT2 receptor agonist, And it's given as a simple bolus injection over a few seconds, and then you flush it through, and then the maximal effect comes within 10 to 20 seconds, and that's when you give the radio tracer. There is one caution, and that is one of seizure disorders, but it's much more well tolerated in those patients with obstructive airways disease and asthma, and so is a useful adjunct to have in your armamentarium in pharmacological stressing. So discussed or mentioned at least stopping drugs before you can actually do pharmacological stress, and this is another question that always comes up as to whether you need to stop the drugs that the patient is on before you do a nuclear cardiology stress test. And indeed, if your patient is not on drugs, the defects and the perfusion defects that you will identify will be larger than if that patient were on their drugs. So you'd be more sensitive in diagnosing ischemia. However, it really depends why you're doing the test. If your reasoning is that you want to assess therapy, then it's important that the patient continues on their medications. Again, if you really want to diagnose ischemia and thereby diagnose coronary artery disease, you might want to discontinue their drugs. However, this decision must be made on an individual basis, and then there's never any sort of will from the nuclear cardiology lab that all patients must come off their drugs. So that's something that needs to be done in discussion with you as the referring clinician, and the patient and the lab to fine-tune exactly on an individual basis what's needed. So a patient has a stress test, and then we need to image them. And the imaging protocols and the choice of radio tracer and how exactly the scan is done is, well, there's a cookbook of ways, multiple ways in which you can do it. So there are various protocols. For completeness, I'll mention the one-day dual isotopes method. There's the 2-day study, and then there's the 1-day single isotope study, which may be done with thallium as a stress and redistribution protocol, or with MIBI tracers where you give rest and then stress, or then stress and then rest. I'm going to go through the most common of these because these are the ones that your patients will more than likely actually have. The 2-day protocol, split across 2 days. You get high quality images of both stress and rest. You can gate both sets of acquisition, and again there's an option if you perform stress first and that is normal, that you can then discontinue the second half of the examination, and the patient receives half as much radiation, and the patient is discharged and with a diagnosis of no ischemia. However, it is a lengthy procedure requiring 2 appointments on 2 separate days, and the arrangement of that can be weeks apart. And there's an increased decision process for physicians because they have to assess that stress-only images to determine if it's entirely normal and then decide whether to bring the patient back or not. As a diagram, this just illustrates stressing, the uptake time with the tracer, in this case MIBI. There's 30 to 45 minutes of uptake time imaging, and then image review, and then if not normal, bring the patient back the second day and repeat the entire exercise but without the stress test. And then you have 2 images which to compare to make your report. More convenient for the patient is the 1-day protocol. So this has got good validation. The image interpretation can be easier than the dual isotope protocol. And you can see some of the ancillary signs of ischemia, such as transient ischemic dilatation, more straightforwardly because you're using the same radio tracer with the same imaging properties. Again, you can perform validated attenuation correction. However, you have to split the radiation dose for this scan, and one image will always have less radiation in it, and therefore will have less quality. If you're going to perform the rest and stress protocol, then you need both images, and again the stress image, the stress rest protocol. In that order, you have reduced quality on the stress images, which are the ones that you really want to have, a good image quality on. And therefore, really, this is a protocol that doesn't really work with rising rates of obesity in the population. Just to illustrate, the patient comes along, will have a stress injection using 1/3 of the total radiation dose you're going to give. Again, the uptake time of 30 to 45 minutes, image acquisition, review, normal or not, and then a larger dose, and that swamps that in the background that will still be there from that initial dose. Bring the patient back 40 minutes later and perform the rest imaging. Then you have the 2 sets of images to do your report. So there's a choice of tracers. I've already mentioned some names, and really this depends on availability and practical reasons. So if you're performing myocardial perfusion SPECT, then you have access to thallium or the technetium agents, sestamib or myovutetrafosmin. Thallium is less popular these days because of the larger associated radiation dose. If you're able to perform PET perfusion, then that means you've got access to a rubidium generator or an ammonia producing cyclotron, or again a cyclotron that can make oxygen water. And these have advantages over the inherent different imaging properties of PET and much less radiation exposure than compared to the SPECT perfusion agents. So there are imaging considerations and some practical considerations, but this is why you may request a thallium scan and you actually might get back a MIBI scan or a rubidium scan. These traces have been largely shown to be equivalent, and there are inherent superiorities with the PET traces over the SPECT traces. With PET, the advantages are that it's very fast imaging acquisition. Your patient is in and out in 30 minutes. In the case of rubidium, with a reduced radiation exposure, the radiation dose from a rubidium PET perfusion scan is akin to 1 year's natural background radiation. Because of PET imaging characteristics, the scan is more sensitive, and there's inbuilt attenuation correction when you're using a PET CT machine, so that you no longer have artifacts to read through. And that allied with the fact that there's a shortage of technetium because of the reactors that make these traces internationally in Canada and South Africa are reaching a certain age and are going offline. The patient journey is much longer with SPECT. Again, as I mentioned, the radiation dose is higher. And intrinsically, if you're using SPECT only cameras, then you don't have attenuation correction, and you have to learn how to read through the artifacts. This is just one meta-analysis that shows that PET just slightly outshades cardiac MRI in terms of sensitivity and specificity on an ROC curve, but the availability of PET in the UK at least is extraordinarily limited. Just for illustration, this is a cyclotron, so it's a pretty serious bit of kit. And this is what a rubidium generator looks like, and it's about the size of a shopping trolley. You can sit at the end of the scanner and can deliver a tracer literally 24/7 on tap. And of course, because as I've alluded to the fact that these are PET CT machines, it means you can combine the PET perfusion with CT angiography. In this case, in this graft patient, where many of the saphenous vein grafts have been occluded, that the lemur is still working, and yet there's still some distal ischemia, presumably in that lemur territory. So for reference to your patients, they very often will have pharmacological stress, and this is combined with low-level exercise. Patients must be caffeine-free if they're coming for adenosine and regadenoson, and there's a potential to reduce the radiation dose if you perform stress-only imaging, stress-first image protocols. Thank you. Please comment below if you have any questions. If you found that interesting, please like and subscribe for more lectures. If you'd like to know more, follow the BNCS on Twitter and visit our website. Thank you.